Second opinions can save lives. Welcome to the Cancer Advisor's Medical Minute podcast. Through care, education, research, and innovation, our mission is to reduce the suffering and mortality of cancer while giving patients greater clarity, better options, and renewed hope.
Hi, I'm Jean Denney, and I'm here with Dr. Jim Essel with the Medical Minute. A little bit of background about myself. I've been an oncology nurse practitioner for about 20 years in a variety of areas of oncology. I've worked with solid tumor patients, gynecologic oncology patients, and a large part of my time was spent with hematologic malignancies. I've also spent a fair amount of time in clinical research in oncology. So I want to introduce Dr. Essel and give him a chance to introduce himself.
Hi, Jean. I'm Jim Essel. I'm a medical oncologist, been in practice for over 40 years as a physician. And during my career, I specialized in blood cancer, so leukemia, lymphoma, multiple myeloma, and then specifically in cellular therapies. And during my career, my team has performed over 3,000 cellular therapy procedures.
Great. So just a little brief summary today. We're going to spend about 20 minutes talking about newer medications and treatments available to patients with blood cancers. And so blood cancers, just briefly, that's leukemias, lymphomas, and multiple myeloma. So Dr. Essel, I'll start with a question. So what do you see as the most exciting or new therapy for patients on the horizon for blood cancers?
Well, I think having the background, I've been doing this since the 80s. Back then it was, let's see how much poison we can put into somebody and hope they survive. Let's give them radiation, hope they survive and the cancer doesn't. And really all the treatments now are focusing on targeted therapies. And with blood cancers, really the first to use cellular therapies that have taken people with relapsed disease and actually produced cures in some cases.
So what do you, can you give an example? Like I've heard of CAR T, and likely our listeners have heard of CAR T therapies. So specifically, what are CAR T therapies? And then I think importantly, what are the differences as far as actually getting the treatment and then the side effects?
So CAR T, or chimeric antigen receptor T cells, were the first cellular therapies that came out for blood cancers. And now we have over 5 years experience. Initially, this therapy where we take T cells or cancer-fighting cells from the patient, they sit on a machine, they're apheresed, it's not painful, it takes about 3 hours. Those cells are then sent to the laboratory where they're transformed, a viral vector inserts an antibody on those. Those cells are then expanded, then they're brought back to the patient. The patient receives 3 days of outpatient chemotherapy. Then these specific cancer-fighting cells are infused into the patient. Initially, these, like with any new therapy, they're used for end-stage people, nothing, and to see if they're safe or not. And in fact, it was amazing how well they worked, but there were a lot of side effects then. As these cells go in and they lock onto the cancer, they release a lot of chemicals. Those chemicals help kill the cancer, bring in more T cells but also those chemicals can cause problems called cytokine release syndrome. And that can cause fever is the first symptom. It can cause lung problems, heart problems, kidney problems, liver problems. And people were dying with this therapy initially. And it kind of scared a lot of people away. We used to think that you had to let this happen or you would block the cancer killing ability of the CAR T cells. Now we know that's completely not true. And sometimes we use prophylactic therapy to allow this to be done as an outpatient and only admit for complications, or initiate therapy to reverse this chemical reaction as quickly as possible. The other thing that we see that usually happens a day or two later, if it happens, is some neurotoxicity. And that's kind of even scarier because the patient can be just a little confusion, headaches, all the way to coma, seizure, death. And again, we've learned how to manage that a whole lot better than we did. And now what we're seeing with CAR T, instead of using it kind of end stage, where we were seeing significant advances compared to the previous therapy, was an autologous stem cell transplant, where we would literally give you a lethal dose of chemotherapy over about 5-day period of time, then rescue you with your stem cells, and about 30% of the people could be cured. With this, the cure rates were even higher. And now two of the drugs that are on the market are actually indicated for second-line therapy, meaning the very first relapse we give this. And we're seeing at 3 years a plateau, meaning that people are no longer relapsing. About 40 to 50% of the people are probably going to be cured. So with that information, now there's clinical trials of using this first line if there's minimal residual disease or in remission, or finding less toxic ones to actually incorporate into the initial therapy to try and prevent that relapse altogether.
Yeah, and now we have, I think too, it's important for our audience to know that we've gotten so comfortable with CAR T therapies. To your point, that we were able to administer them outpatient, but providers have become much better at administering them. So the staff is more experienced. The side effects are managed much more quickly and recognized much more quickly. And just to clarify, these therapies, CAR T is available for lymphomas and leukemias. Now, for leukemia, definitely not first line,
right,
but upfront. And then, what about multiple myeloma? I know there's some clinical trials, but where is CAR T with multiple myeloma right now?
So multiple myeloma is it's still considered an incurable disease. And CAR T, again, was originally kind of end stage given to people. And with the drugs that are out there now, about a third of the people at 3 years, at 5 years, are in remission, which is amazing because these people, if you're a patient with myeloma, you're on this continuous progression of one therapy after another. You never really get a break. And so with that information and trying to make it safer, it's now indicated second line, so at the first relapse. In that group, about 2/3 of the people at 3 years are still in a complete remission. And we think there may even be some cures from this, which would be amazing. Using the cure word for myeloma has really never happened. And with that, we're also looking at clinical trials using it as part of the initial therapy. So use kind of standard therapy to get you in remission instead of what would be the standard of care doing an autologous stem cell transplant. And again, giving a very high dose of chemotherapy with a lot of side effects, rescuing you with your own stem cells. Instead of doing that, use CAR T once they're in remission. And we're seeing long remissions with that. And I think at some point we're going to be using the cure word for myeloma as well.
I agree. That's very exciting about myeloma. So do you think that with, CAR T, so let's switch to, I've heard of, or there's a lot in the news about, they're called BiTE therapies or bispecific T-cell engagers, which is a mouthful.
Yeah.
But they're, again, newer therapies, but still different from CAR T. So just can you give a little explanation about BiTE therapy?
So again, the focus is on using your own immune system to treat the cancer, not giving you poisons or chemotherapy. Bispecific T-cell engagers or BiTE therapy, most cancer patients, or especially blood cancer patients, have received monoclonal antibodies. That would be rituximab or daratumumab for myeloma and lymphoma. It's a naked antibody that goes in and it sticks on the cancer cell, and you kind of hope that the body's T cells recognize it, and it definitely does help the chemotherapy and the other regimens work better, but it's really not curative. It's just an adjunct. What a bispecific T-cell engager is think of it as has a magnet like the monoclonal antibody that sticks on the cancer cell, but also has a magnet that actively pulls the T cells in. So one of the advantages of this is that with CAR T, we talked about cytokine release syndrome and neurotoxicity because it's a one and done. You give this huge dose of cells, and then they do their thing, and hopefully you're cured and you go on and no other therapy. With bispecific T-cell engagers, we can start off with a small dose. We do what's called step-up dosing. It takes a few weeks to try and mitigate those side effects, so kind of easier to do, and then eventually you're on a maintenance therapy, and usually that's once a month, to keep yourself in remission. So it's different, kind of easier up front, but goes on longer. But definitely it's an adjunct. This is something that's used by itself for lymphoma and for myeloma. And now there's just numerous studies of combining it with other therapies up front to try and, again, produce a cure and avoid relapse altogether in these diseases. So it's super exciting time that we're using your own body to fight the cancer instead of what we did in the past.
Now, would a bispecific, like a bite therapy, that be one course of treatment, or is that something that I could go back to? And I mean, is it just a treatment of over several doses and then you're kind of finished with it?
Well, there's a couple of things. First of all, CAR T got approved first, so it's got earlier lines of therapy. So the typical large cell lymphoma patient that's not on a clinical trial is going to get CAR T. Hopefully they're cured. We said 40 to 50%. But in that other half of the people that aren't, the bispecifics that came out, the antibody on the CAR T cells is a CD19. So one of the ways the cancer can avoid detection of these is it loses that protein CD19.
Mm-hmm.
So the bispecifics, fortunately, are CD20. So then you're picking up at different cells. And I've seen patients that blow right through CAR T and you're thinking, oh gosh, before we had bispecifics, we really had nothing left. We would try chemo, just didn't work. Now you can add the bispecifics, and I've seen patients go back into a complete remission where CAR T didn't even work. So it's usually kind of one and the other. The other area, and it's not standard of care, but people are doing it, is someone relapses. The worst of the worst are the relapse refractory, meaning you're getting your R-CHOP for lymphoma, and maybe you show a little shrinkage, and then you grow right through it. In the past, these patients, we tried and honestly, the vast majority just died. Nothing worked because they were refractory to chemotherapy. In that group, it doesn't make sense to give a different chemotherapy to get into CAR T because it usually doesn't work. So here you can use a short course of a bispecific, get them in remission, then follow with CAR T. So we're still learning a lot.
Right. And I know that in leukemia, like CAR T can be used as a bridge to an allogeneic transplant, meaning that I know some patients who have gone into a complete remission with a CAR T, and then that enables them to go to an allogeneic transplant where they were unable to go into remission before.
Exactly. So, to take someone into an allogeneic transplant with active disease, it just doesn't work very well. You're looking at best maybe a 20% cure rate, which is better than zero, but not very good. But if you can give CAR T and put them into a complete remission, you make those numbers a whole lot better. The CAR T, though, usually doesn't produce the cure, so you're right. It's a bridge to take you into transplant. And they're working. There's experimental studies going on right now for those are B-cell ALL, and there's now studies for T-cell ALL, which relapsed T-cell ALL is a horrible prognosis, and now we're seeing people go into remission and then transplant. And then AML is a much kind of tougher thing. There's research. We're starting to see progress, but those AML, acute myeloid leukemia cells, tend to mutate more, and there's more work to be done, but there's a lot of work on that right now.
So, in 2026, what is if you look at the country, like across the country, what do you think is the availability and how much are providers? My question is, do patients need to go somewhere to a specific center, or are CAR Ts and bite therapies pretty standard of care in academic and community cancer centers?
That's an excellent question. And the problem is only about 20% of people that should be getting CAR T are getting it. And there's a lot of reasons for that. If you live out, in the Rocky Mountain area or out in the middle of the country, you may have to travel a long way. Some people just can't do that. If you're in a big city with an academic medical center or an advanced, private practice, you can do it. But there's still a lot of physicians that look at the old data when it was very toxic and patients and aren't referring patients. We've had many octogenarians cured with this therapy, and we're still a lot of those patients aren't being referred because the perception is too toxic. The other thing to point out with both of these therapies, you have to have a caregiver, because if we're doing it as an outpatient or even the neurotoxicity as an inpatient, who knows a personality change in you better than your spouse or children or things like that. That's a barrier for some people. And it's not just one person traveling. Let's say there was nothing in Cincinnati, which there is, and you had to go to Columbus. It's not just the patient going up there. Somebody else is taking off work, for weeks to go up there with them. And sometimes that just can't happen. It is fortunately being paid. It's standard of care, so it's paid by insurance companies. But there's a lot of work to be done. And I know the companies that produce these are trying to get more community practices to do it. It takes a combination with the hospital, and it's very, very expensive, and the practice to make sure it's done right, reimbursements correctly. The treatments for CAR T are about $500,000 just for the cells. So if you're not reimbursed, that's a big hit for the hospital. So and I hate to say it, but that's a barrier too. It's just the cost of it. So it takes an entire team to do this. It's not, a physician can't do it. You need to train the nursing staff. You need to train the emergency room when they come in. We even, interestingly, one of our nurses' husband's a fire chief in town. And when this first came out, if someone gets confused with neurotoxicity and they call 911, we didn't want them going to the stroke center where they, that doesn't do CAR T. Right. So we actually call the local firehouse and say, this person needs to go to this hospital if they call you. So it's just the team and training to get this is pretty enormous, but it's worth it because you're helping patients.
Right. And I think to your point, I think if you're looking at older safety data, that it can be extremely intimidating. But from my experience in giving CAR T and then examining side effect profiles of CAR T and BiTE therapy, nurses and Oncology Nursing Society and other organizations have done so much to educate nurses, and so again, it's that final step of getting that not only to the patients but then to the providers about how much better and how much more we know about it. So if I was a patient, and I know, and I have some resources that we can talk about, I think, but what are some ways I think helping patients navigate the complex therapies of blood cancers? Because as we just said, multiple myeloma, it is unusual that a multiple myeloma patient would be on one therapy, or same thing with a lymphoma or a leukemia. So what are some kind of patient ways to navigate that complex therapies?
So I think most oncologists in the region feel comfortable treating a new myeloma patient or a new lymphoma patient. At the time of relapse, I think it behooves the patient to ask the doctor, should I see a specialist? Because those are the people that have the expertise, and these are available in multiple of the hospitals here in town. Those are the people with the expertise. They're the ones going to the specific myeloma, lymphoma, leukemia meetings, and they see these patients every single day in their practice versus a general oncologist sees that new myeloma patient once every 6 months. So I think doing that, and patients shouldn't be afraid to ask for a second opinion. I always tell my patients when they bring it up very sheepishly, do you mind if I go here for a second opinion? I'm like, if your doctor doesn't want you to a second opinion, by definition, you need a new doctor because it's your life and it's important, and they have to feel comfortable with your decision. I've treated, CEOs here in town, and day one, I'll say, you're going to get pressure knowing who you are. Let's send you for a second opinion right up front so that you can tell your coworkers and the board of directors that you're getting the right therapy. So people just should not be afraid to do that. And once you've relapsed, I think is definitely the time to at least seek a consultation. And they may say, your doctor's doing the perfect thing. Go back to that doctor. We're here. But don't be afraid to ask for a second opinion.
And so then I think the other thing, too, is that, I always tell patients there's, so much chatter. And the party line I always said was that the only thing similar between you and somebody else is the word cancer. And I think it's important to empower patients to find out specifically your cancer and your, genetics or your risk factors, and then the options for your particular type of cancer, because we know that even just a diagnosis of multiple myeloma, one size does not fit all. And many times patients may have an extremely favorable prognosis, and not get caught up with what other people have said about multiple myeloma.
I think you're absolutely spot on. Everything in cancer, not just blood cancers, across the board. We used to breast cancer, and then we divided into hormone positive and negative. And now it's all about the genetics of the cancer. And that's part of the targeted therapies is looking for a genetic mutation and treating that with a targeted therapy. Again, not just a shotgun of chemotherapy and hope that it works, but actually looking for it. And that makes everybody's cancer really is unique. And the treatments have to be individualized. And that's going to be more so as we move into the future.
And we know from clinical trials and the studies that the industry and academic centers are running, is that they are running these trials are called basket studies, meaning that, for instance, the study is looking at a specific mutation, but in multiple tumor types. So you may be enrolled in a clinical trial for breast, colon, lung cancer, esophageal cancer, pancreatic, ovarian, because it's looking at one genetic marker. And I think it's, our treatment of cancer is going to become much more specific to the mutation, not to, the tumor type.
Yeah. In the past, it was a phase 1 drug was a drug that worked in animals, and then you would do it in humans, just trying to find the dose. It was a mixture of all these different people that had nothing to offer. And, 3 of the breast cancer patients responded. It became a breast cancer drug.
Right.
And it's completely different now. Now, even a phase 1 is designed to treat that specific mutation.
So just kind of in wrapping up, there's a couple of things I think we can talk about for resources for patients. You and I have talked about this a lot, but one amazing resource for patients, not only for clinical trial resource, they even have patient navigators, is Blood Cancer United. This is formerly the Leukemia and Lymphoma Society, and I kind of joke, I don't know if the myeloma patients got offended because they weren't mentioned in the title, but now Blood Cancer United is what the Leukemia and Lymphoma Society was, and we have heard that, Leukemia and Lymphoma Society, over and over. They have team in training, they run marathon, that kind of thing. They're extensive, but their website you can even contact a nurse navigator. They have clinical trial resources. They have resources in your area. So that's one big resource.
The other thing with them, just to point out from an emotional standpoint, for the listeners who participate in Light the Night and those that haven't, it's a great event. It's not a run like the Komen Run. It's a walk. It's at night. It's very moving. They usually have people telling their story. And I would highly encourage people to get involved with Light the Night. It's always in the fall. It's down in Sawyer Point, and I believe they have one in Mason as well, and they're all over the country. It's a great thing for people to get involved with.
Yeah, agree. It is a great event. Then, so what would then there are a couple of other really basic, I think, reliable clinicaltrials.gov, but I don't want to underestimate having establishing a dialogue with your physician, and like Dr. Essel said, say, kind of questioning them and saying, do I need to see someone else? Do I need to get this verified? And just from our practice, I can't count how many times we saw an unusual pathology and got a second opinion on the pathology. That's an extremely reasonable request for patients. In my practice, I cannot count the number of times where the pathologist said, 99.9% sure that it's this. There's this strange element. And, we would send it off to a national center as MD Anderson and I think, too, and you can comment on this, I feel like in the past 5 to 7 years, pathology has been getting weirder or less, do you know what I'm saying?
It's because we're individualizing the cancer so much that it's not just literally when I first came back to Cincinnati, the pathologist would take the slide and say, acute leukemia, next case. That's not how, and there were some where they made a mistake. That was something else. Now, they never do that. There's flow cytometry, there's NGS testing, there's cytogenetics. It's so much more complex. And the more complex it is, the harder it is to make a diagnosis. And you're absolutely right that sometimes that second opinion is someone just reviewing the radiology, the pathology, and kind of putting all that together is very important.
Yeah. But again, and that's a better way of saying that it's weirder, is that we have more information. Because now it used to be we didn't always order flow or NGS or these specific tests. And now most of the time, all of the tumors and everything gets looked at like that. Do you have anything else that's any other things that are new about CAR T?
Yeah, one of our speakers that we had at our ASH review 6 years ago said, you're going to look back and this is going to be the iPhone 1. And I love that because we still use the iPhone, but it's so much better. And we mentioned that people develop resistance by losing the protein that the antibody sticks on. So now you're looking at putting 2 antibodies on the CAR T cell, and bispecifics are going to be trispecific. So instead of just one, it's harder for the cancer to mutate. The other thing is some of these patients, by the time they get to CAR T, they're so beat up with chemotherapy, their T cells don't work anymore.
Right.
The other thing that can be and what's really a disaster is if you're all set up, they're ready to get this life-saving therapy, and you can't collect them because for whatever reason, there's either a technical problem, their T cells just aren't viable. Now we're looking at using CAR T that actually grows inside the body, in vivo growth, and that looks like it's going to significantly decrease the toxicity. So instead of giving this huge dose, millions of cells, you have a smaller dose, and they grow inside your body and then start working on the cancer. The other thing people are looking at is allogeneic CAR T cells, and this may be something that'll actually bring the cost down. When you think about CAR T, if you have lymphoma, you have to be apheresed. We take your cells for one person, just for you, take them to the laboratory, grow them, do all these different things, and infuse those back in. If you can take healthy young donors and you can get 20, 30 treatments from one apheresis of this young person, you should be able to make it cheaper. You avoid the problem of collection. You avoid the problem of time of growing these cells out where the cancer may be growing and you relapse before you can get the cells back. There's a lot of work to be done, and there's no allogeneic cell CAR T on the market, but I think that will be something we'll see in the future. So the future is bright. And again, I tell residents, you're going to look back and the medical students that you have, and they're like, you gave chemotherapy? Really? I mean, people did that. Their hair fell out. They were throwing up. And now it's going to be targeted therapy. It's going to be immunotherapy, cellular therapy. And it's never a good time to have cancer, but it's a whole lot better than it was 20, 30 years ago.
Yeah, that's great. Well, thanks for joining me today.
Thank you.
And thanks
My
for
pleasure.
being here. It was a great conversation.
Thank you for joining us on the Cancer Advisors Medical Minute podcast. We hope you'll join our communities online and support us in our effort to reduce suffering and mortality for all those affected by cancer. And for our next episode,